want to say that I really appreciate being an honorary member of this club, and Betsy and I really enjoy coming to these meetings. I want to particularly thank Mark Allen for inviting me to talk today, I think, as maintenance certification seems to evoke visceral responses from certain people. But what I want to tell you is I think Doug led in very nicely to my talk, because it's all about quality, and you're hearing it, right? It's going to affect people who do cardiac surgery. It's going to affect our diplomates who do general thoracic surgery. And we have the opportunity to self-regulate. And it is very clear, you've seen it already, if we don't self-regulate, they will do it for us. And whatever I present today will be much more onerous if we weren't doing it ourselves. So I'd like to address you all with this, and hope I can convince you that, in fact, we're trying to move in the right direction for the benefit of our diplomates and for cardiothoracic surgery, and most importantly, our patients. So I don't have any disclosures today, except from being home of the Super Bowl champions. And I apologize for all the 49er fans who may be in the room. And of course, the New England Patriot fans. I know, it's shameless. It's just part of me. So let me give you a little background of where the ABTS sits in with the American Board of Medical Specialties. So there are 24 member boards. There are 36 general specialty certificates, of which we give one. There are 111 subspecialty certificates. Again, we give one, most recently in congenital heart surgery. And if you look at the number of physicians who are certified in the United States, you can see that there are about three quarters of a million people. But there are a lot more that are not board certified. Now, if you look over since the board started in 1948, and since that time there have been 8,000 certificates issued. And as we look at all of our active CT surgeons, there are a little over 4,000 in the United States. So certification is seen as significant quality measure by a number of organizations that are listed here. The Joint Commission, the NCQA. I want to talk a little bit about the Federation of State Medical Boards, because I think, again, that affects all of us for our state license. Of course, healthcare institutions are looking at this, as well as we are seeing increasing number of payers. And of course, our patients use certification as a way to indicate quality. The ABTS has had a long history of recertification. We were one of the few boards that really started recertification early on. And as most of you know, it was through CSATs, kind of an open book test where you took it, sent it back in, they gave you your results, and you had a chance to then re-review the questions. But in 2000, under the auspices of the American Board of Medical Specialties, all the boards agreed to evolve the recertification programs to one of continuous professional development. And by 2006, they had come upon a structure of how it should look. And the ABTS first started their MOC program in 2008. And basically, it ensures that board-certified physicians maintain competency in a specialty. But more importantly, it is a commitment to lifelong learning. So as I mentioned, our maintenance certification or recertification program started in 2008. We currently have a 10-year cycle with a 5-year milestone. And somewhat controversial, but we The board back in those deliberations in 2006, 2007, 2008 said that there should be no grandfathering for any ABTS diplomate. Now that varies across the boards. American Board of Internal Medicine, for example, they grandfather. And I don't know if any of you are familiar, but there was a New England Journal paper written a while back that was talking about the issue of grandfathering and the pros and cons of it. We think that our patients, if deserve diplomates to stay up on their profession and to be an active participant. So there are a few other surgical boards that do that. We were one of the first. But you can see that the maintenance certification program has been extensively used now by a little over 1,500 CT surgeons that participate. So what we'll have, the designation will be, you're board certified, but also it'll be meeting the requirements of maintenance of certification. So it'll be two things that'll go on our website and also on the American Board of Medical Specialty website. So I think many of you, of those 1,500, I suspect some of you in here have gone through the process, but there are 4 parts to it, and with the 4th one being probably the one with the biggest impact. But part 1 is that physicians must hold a valid and unrestricted license in at least one state. Part 2 is the lifelong learning part of this, and that is CME, but also it's important that one participates in some type of self-assessment program. Of course, we're very fortunate to have CSATs as part of our portfolio that David Campbell has really led for many years, and I suspect a number of you in here have participated in writing questions for David and CSATs. Part 3 is the cognitive experience, and so for the first time we now have a secured exam. That exam has been given 3 times. We have within the board a MOC exam committee. David Harple really was the one that helped spearhead this initially. And this is an exam similar to our qualifying exam for the board. It is rigorously looked at. The psychometrician goes over it with it. Mark Allen is part of the whole process and examination. It's reviewed very carefully. And the last is part 4. Practice performance assessment. So we're asked to demonstrate how we assess the quality of care that we provide, and then how they can improve that care. As Doug mentioned, we have had a very nice collaboration with the STS. It's actually very convenient to have the STS and the ABTS on the 23rd floor of the American College of Surgeons building. I go up there once a month for 2 to 3 days, and then I can easily drop down and see Rob or Damon or Graham and to talk about things. So they've been very involved. They've produced a task force that looked at MOC requirements for a patient safety module that all of us will need to take as part of fulfillment of MOC. That actually is really coming down to a completion and will be reviewed by the board at our spring board meeting. So that's just an example of how the collaboration exists. And one other is, I'll mention in a minute, that we're working on to facilitate on how within one's practice, you improve a certain aspect of it. I also get to participate, of course, in the NCAA pools and the Super Bowl pools and everything else that goes on within the STS structure. I shouldn't say that, should I, Rob? George could be getting into trouble. So let me just review with you what the 5-year milestone means. So you have to have an active, unrestricted medical license, 2 letters of reference, one from your Vice President for Medical Affairs or your Chief Medical Officer, someone else on your staff. Then under lifelong learning, 150 AMA Category 1 CME credits, so 30 a year over the past 5 years. Half of those have to be in the broad category of thoracic surgery. And under cognitive experience, you have to take and complete the current version of CSATs. So that's 5. Under 10, the 10-year milestone is similar for professionalism, similar for lifelong learning, same number of CMEs, half of which have to be in thoracic surgery. And the cognitive experience, this is the secured exam. As you know, you can take just like you can take the exam 2 years before your date, and those are the pass rates for 2010, 11, and 12. And they are based upon CSATs 9, and the next one will be based upon CSATs 9 and CSATs 10. We can see who looks at CSATs 9, and there's a direct correlation to doing CSATs 9, passing the exam. And likewise, if people who didn't pass the exam, it's highly likely that they didn't look at CSATs 9. So for our point of view, we think that's a learning opportunity. So, one goes through CSATs 9. I agree with many people in the audience who would say, well, I don't get anything out of looking at congenital or cardiac since I only do general thoracic. On the other hand, we have actually a number of people who say, in fact, I get a lot out of it. Actually, I get a lot out of sitting in these sessions in general thoracic. I learned a lot from Paul Noble. I know all about honeycombing, subpleural honeycombing now, what that means. So, as I said, those exams are all rigorously looked at by our psychometrician. And finally, practice performance. We asked that you send us a case summary of your last year's cases, and you participate in a database or registry. We had allowed that you could participate in was the CTS-Net portfolio. That has been migrated onto the ABTS website. But as you'll see in the future, we are not going to allow that anymore. So you heard from Doug, the gold standard for databases is the STS. We have a number of approved databases that I'll show you. But the board voted to require database participation starting in July of 2014. So the portfolio will no longer be a valid way of maintaining your maintenance of certification. This is consistent really with all the boards, including the American Board of Surgery. These are some of the ABTS approved databases with the STS at the top. And as you can see, we also allow VA, NISQIP, Northern New England, the California, Massachusetts, Michigan, New York, Pennsylvania, and Washington state databases. One of the themes or criteria that is pertinent to every one of these is that they can be benchmarked. Your data can be benchmarked against a national or regional group of surgeons, and that is a very important part of what we are going to be judged as surgeons in the future. So why the switch to maintenance certification? So it acknowledges growth and complexity of medical science. It acknowledges the importance of a physician's relationship with the patient in delivering patient quality outcomes. And it's a profession response. It's our response to the need for public accountability and transparency. And this is becoming increasingly an important part of self-regulation. And it's our potential to compare to peers and national benchmarks. It also demonstrates a lifelong learning. and a commitment to achieving quality of clinical outcomes for our patients. So these are just my personal goals for MOC. It needs to be meaningful. It can't be just to check the box that was done. It has to improve some aspect of practice, which will result hopefully in better patient care. It has to be at a reasonable cost. We're currently at $250 a year. That hasn't changed for the last several years. And if we give CSATs away for our diplomats who are involved in the 5-year milestone. It has to be a reasonable time commitment. And one of the, we think, important things is to reduce the duplication of requirements. I think many of you know what OPPE is in your own institution. I'll show that in a minute. I mentioned maintenance of licensure. So the Federation of Medical License Boards are under the same pressure to do something to demonstrate that the physician is a competent physician. Now, I grant you competence is a difficult thing to define, but they are developing not too dissimilar maintenance certification requirements. So the ABMS worked with the Federation, and if you participate in MOC, then you will qualify for MOL, future MOL. Right now, for MOL, right, all you do is document or even just a test that you do so many CMEs, you send your money in and you get your license. But in the future, they're going to have requirements similar to MOC for those who are not board certified through the ABMS. They'll have to carry that out. For those of us who are and participate in MOC, it counts. And finally, for PQRS. I think most of you know about this, but if you don't, OPPE started in 2007. It requires 3 activities: continuous systematic measurement of physician performance, periodic evaluation of the results of that measurement, and follow-up to address any performance issues identified through the evaluation. This is just part of hospitals. And MOC can actually meet the majority of those requirements. So what's the board trying to do to help move this along? We've created, our database for our diplomates was really very old and not very interactive. So working with a company that has done some database work for the American Board of Plastic Surgery, Orthopedics, and Pathology, we've developed a total electronic application process. I think those of you who have participated in MOC know you scan your documents, you upload them. If you don't do a certain thing, it won't let you proceed. So it has, and we have an audit for that, so you don't have to list all of the certificates in CMA. You just list what you did, but there's an automatic audit function that you may have to show those certificates to verify that you indeed went to that particular conference. We continue to provide the CSAT. CSAT's 11 should be out this spring. Dave Campbell, of course, is spearheading it. Many of you are writing questions, and we're working with a new company that will have it available not only on your desktop, but it'll be available on your iPhone, and it'll be available on your iPad. CME opportunities, and this is where I mentioned we're working with the STS with this patient safety module. Remember, we are a certifying and a recertifying functions. We're not involved in education, and that's why the really good collaboration between the board and the STS works extremely well for us. Damon is working on what is called Performance Improvement CME. Give you an example. So over every 5 years, this isn't we don't have a defined date by this, but probably by 2015, and it may be earlier, you would have to show some improvement or not show improvement, but show something that you did to improve your practice. So for example, say in the SDS database, you're an outlier when it comes to blood transfusions. So you would decide that's the function you want to do, the process you want to do. You put in a plan to correct it, and then a year later you measure it. And that kind of process is performance improvement and counts for part 4 of your MOC. And Damon's working to see if we can't get CME for this. That is not a definite, but Damon, for those of you who don't know, he's a bulldog and tenacious to try and make that happen. But that will be part of part 4 in the future. Database participation first, and then performance improvement modules after that. So the MOC committee is deliberating on a number of future components. I mentioned patient safety, peer review survey, and patient satisfaction survey. We're probably going to be able to use what many hospitals already use, and that is Press Ganey, that we can allow that to be used for it. And as I mentioned, the last one is documentation of some performance improvement module. And the closer we can make it to routine process of care, the easier it is for those to be able to carry it out. So in summary, maintenance certifications here to stay. Self-regulation rather than have CMS do it. We've right now are continuing with a 10-year cycle and a 5-year milestone. There are other boards that are actually doing this every 2 to 3 years. We're right now we're at these cycle lengths. It may change, but at least right now it's where we are. We want to make it meaningful, but not onerous. And the hope, of course, is that through lifelong learning and an educational process, we'll become better CT surgeons for our patients. I want to thank you again for your kind attention.